been waiting for. Dr. Stuart Jameson will talk to us about pulmonary endarterectomy.
Well, thank you very much. So in the next 10 minutes, I would like to discuss our experience of 30 years and now 4,000 cases of pulmonary endarterectomy. The rationale for the operation was pointed out by Trendelenburg many years ago because the pulmonary parenchyma, of course, has a dual blood supply from the bronchial arteries as well as the pulmonary artery. So it's one of the unique organs that thrombosis or embolus doesn't result in tissue necrosis. So when you revascularize it, you once more can regain function. The aim of the operation then is threefold. The most common one, of course, is hemodynamic. Patients get into right heart failure, but also alveolar respiratory because ventilation is impaired. What many people don't understand is that a very important part is palliative, because more and more we see in people with this long-term, they develop small vessel disease, and that's inoperable except by transplantation. And with the good results of surgery now, we tend to do this operation more and more early. So the operation is something that there's a significant learning curve. Mandatory is it has to be bilateral. You don't get pulmonary hypertension even with complete unilateral occlusion of the pulmonary arteries. So if you have pulmonary hypertension, you've got bilateral disease, and the operation cannot be done without circulatory arrest. It can be done. I mean, you can operate on anybody. Shamway used to tell me, you know, everybody's operable. But whether you get a successful operation or not is a separate issue. And if you want a successful operation, you have to do circulatory arrest because it's simply impossible to see in the distal vasculature without completely emptying the circulation. So we do a median stenotomy to get a bilateral approach. Very obviously go on cardiopulmonary bypass to affect cooling. Circulatory arrest is mandatory. We treat both pulmonary arteries, and fundamental is a complete endarterectomy on both sides. Very often, of course, since these patients, many of them are older, they need other cardiac procedures, valve or coronary procedures or ASD repair, and this can be done during the rewarming period. I think these are the 5 important points of the surgery, and I'd like to emphasize them today. Firstly, the head. Obviously, with circulatory arrest, there's a concern about problems with the cerebral circulation. Here you see a fairly typical appearance of the monitor. You can see the pulmonary artery pressure there. The systolic is 125. It's higher. It's almost as high as the systemic pressure, 129, and that's characteristic. So we wrap the patient's head in a cooling blanket that's circulated with cold water. And this was modified after an orthopedic type of blanket, and we think it's significant. Here's an assessment of the jacket in 55 patients. You can see we're down to 20 degrees with bladder and rectal, but the tympanic temperature, which is reflecting the cerebral temperature, is 5 degrees cooler. So it gives you a significant benefit to use that jacket. So we go on bypass, we cool to 20 degrees. We put in both pulmonary artery and left atrial vents. There's severe bronchial circulation in these patients as a result of their pulmonary artery occlusion. We expose the right pulmonary artery between the aorta and the superior vena cava. We do the left side and then the left side. We do the right side, then the left side under circulatory arrest. So the technique of the circulatory arrest is to cool to 20 degrees. Then we arrest for 20 minutes each side, and we adhere to that firmly. Then there's a 10-minute reperfusion period, again at 20 degrees, and then you can arrest for another 20 minutes if you have to. So you can, if you maintain this technique, you can have a total arrest time of 1.5 hours without sequelae. Of course, once you're experienced in the technique, you usually get each side done within the 20-minute period. The next important thing is the plane. These are the instruments that we use. Number one is a cerebellar retractor. 2 there is the long DeBakey forceps. 3 of these dissection instruments that we use, and you cannot do the operation properly without them. There's a little ball on the end, you put the suction catheter on it, and you dissect and also get rid of any blood. Number 4 is a small endarterectomy. Here's the operation on the right side. You can see the superior vena cava. And the right pulmonary artery is exposed between the superior vena cava and the aorta. And we raise the plane. We're now under circulatory arrest. Try and raise the plane posteriorly. And the reason for that is if you raise it posteriorly, you can then cut normal thickness pulmonary artery where you're going to make the incision so that you can repair it. If you completely endarterectomize the main pulmonary artery in that area, should you have any residual pulmonary hypertension, the suture line will leak, of course, and then it's almost impossible to repair. People often say, you know, what's the exact plane? You know you're in the plane where it strips very easily. It's halfway through the media. It's all intima, halfway through the media, and you leave the adventitia behind. And it should strip easily. It looks white, it's smooth. If you get too deep, you see this pink appearance, and that's adventitia, and you should come back to a more proximal plane. What about the disease? Well, many years ago, we described 4 types of disease. Type 1 is where you see major vessel clot when you open the pulmonary artery. Probably the most common is type 2. There's no vessel thrombus. You see thickened intima with webs. When you open the pulmonary artery, you often see nothing abnormal. But you look very, very distally, you can see these webs, and that's very helpful because you can grasp the web with a long forceps, and then with the dissection instrument, you push against the web and you can get into the plane. We're seeing more and more of type 3, which is very distal disease, where the disease is only confined to segmental and subsegmental branches. And type 4 is not thromboembolic disease, it's a pulmonary hypertension from other causes. This is a typical type 1. I think the lesson looking at type 1 is that if you just remove the thrombus, you won't relieve the pulmonary hypertension. The key is to remove the secondary thickened media and intima. This is type 2, there's no thrombus, and more we see these type 3 where you have to go into each segment and remove the disease, and obviously that takes a little more time. Next, the pulmonary vascular resistance. What exactly is the effect of high pulmonary vascular resistance? And it's been said and been established that a high pulmonary vascular resistance is a significant risk factor. 15 years ago, we analyzed our first 1,500 cases, and we looked specifically at pulmonary vascular resistance. And it was true that we found that if the preoperative pulmonary vascular resistance was less than 1,000, the mortality rate was low, and was considerably higher if the preoperative pulmonary vascular resistance was over 1,000. But regardless of the preoperative pulmonary vascular resistance, if the postoperative pulmonary vascular resistance was less than 500, the risk was low. But if you were left with residual pulmonary hypertension, the risk was enormously elevated. And so the lesson there is the key to success is complete resolution of the obstruction. Don't worry about the ischemic time. It's get rid of all the disease. Finally, distal disease. We reviewed 450 patients that had their PTEs between 2009 and 2012, and we looked specifically at the type 3 disease. And looking at the patients with a preoperative PVR of over 1,000, you can see about 20% in each were type 3 disease and non-type 3 disease. And this was bilateral type 3 disease. Here you can see the mean PA pressure in the two groups, preoperatively and postoperatively, the cardiac output preoperatively and postoperatively in the two groups, type 3 and non-type 3, and the PVR, type 3 and non-type 3. And the lesson is that although the PVR post-op is slightly less than the non-type 3, you can get the PVR down very substantially and almost compatibly in type 3 disease. So patients with type 3 disease achieve a significant reduction in PVR, even if you start off with a PVR of more than 1,000, and there was a similar perioperative mortality. We're often told that patients have inoperable disease, and really that depends on the surgeon and the center experience. We believe there's no degree of right heart failure or pulmonary vascular disease that's inoperable. And I believe that generally, if the etiology is thromboembolic, it's operable. You may not get the pulmonary vascular resistance down to totally normal, but you'll benefit the patient quite immensely. One of the most satisfying things in my career is that 30 years ago, only UCSD was doing the operation, but now this entity is widely recognized, and many other groups internationally are doing this difficult procedure with excellent results. Thank you very much.
Thank you, Dr. Jameson.